Zoe mentioned, I came to this field somewhat circuitously. My PhD is actually in history. I earned my PhD in history from UCLA in 2008. My dissertation was on the beginning of narcotics control in the early 20th century, focusing on France and England. Now, those of you may have friends who are North Campus PhDs. And one thing you know is none of them are going to get jobs doing what they're trained to do. The academic job market for the humanities is, 300 people applying for every job. The one job is at Northwest Montana Community College, et cetera. So for me, I kind of had started looking at the job market, but then what happened is as I was starting to really look, one of my committee members, Dr. Joel Braslow, who you might know, he's a researcher in the psychiatry department and also a PhD historian. He had a project where he needed clinic ethnographers. So I basically didn't want to leave LA and I said, okay, I'll do it. And then basically from there, that's how I learned about this world of behavioral health, not as something abstract as a black turtlenecked academic on North Campus, but as someone really in clinics and in clinical spaces and seeing how it operates. And then from there, I've kind of weaved and turned into becoming a health services researcher at Integrated Substance Abuse Programs, which is a group within psychiatry that does some clinical work, but also a lot of policy and health services work related to addiction. So basically, what I did here, when Zoe asked me to talk, it seems like it's pretty open as to what might be of interest to the group. So I put together a few slides just with an overview of addiction as I see it kind of through a political, sociological lens and some of the key issues, and it's only some of them. I realized after I put the slides together, oh my gosh, there are so many things I didn't put in. But we want this to be more of a conversation than a real presentation. So that said, this is what we have. It'll be mostly Q&A. Hopefully this will generate some interesting discussion. Also, feel free to interject if you have questions along the way, or as Zoe said in the chat, and Zoe, I think you'll be monitoring the chat for me. So that said, let me now proceed. So you all know this because it sounds, at least talking to Zoe and Laura and Yuki, you all are kind of in what we call the hard sciences. You were the ones who really look at brains and things like that. So as you all know, addiction is a brain disease. Now, this is something that's really become a mantra in the last 20 years, particularly as neuroimaging has advanced. And really a watermark in this was the development of this kind of brain imaging, where scientists and also the general public could say, wow, it is a brain disease, because look at how different the brain on the left is from the brain on the middle to the brain on the right once recovery has taken place. So really that has been a game changer for the field. And in particular, there was an article in 2000 by Tom McClellan, who's with the Treatment Research Institute in Philadelphia. Also, more interestingly, a former drug czar. We often think of the drug czar as very much a law and order position, but McClellan was very clinical in his orientation. And he wrote an article in JAMA that, which as you know, the Journal of American Medical Association, really the highest impact journal there is, talking about how addiction should be seen as a chronic disease. What he did was he compared addiction to other diseases like asthma and diabetes and talked about, well, it's kind of similar in that it's a physical disease. People relapse, but you can live with it chronically. And if you look at rates of treatment, if you consider recidivism for diabetes, someone's sugar going up versus someone falling out of recovery with a relapse, the rates are actually not that different. So this has a lot of downstream effects that have really dominated the field for the last few years. The big one is that it's a disease, it's not a moral failing. And those of us in the addiction treatment field, and particularly people who have been in recovery themselves or have family members or loved ones who've been in recovery, this is something they always talk about. It can be managed through behavior modification and medication. So rather than thinking of it as a punitive issue, really more and more focused on a health issue. Also, something that the health services world has come up with is this point in the bottom left, which is if untreated, it makes people sicker and it makes them die earlier. A lot of research in the last 20 years, particularly out of Kaiser Permanente in Northern California, has looked at people with substance use disorders versus matched controls and finding all kinds of diseases, yes, mental health, but also a lot of physical disease because of the fact that people with substance use disorders just tend not to take care of themselves as well. They don't go to the doctor as much. So this is where insurance companies and people who think of healthcare kind of economically become interested in that, well, this is something we can invest in to make people healthier overall. And then also we know from studies that people with substance use disorders, on average, they die about 30 years earlier than the rest of the population. So understanding that this is really a health issue. And then this point here on the bottom right, that it's discrimination then to treat it differently from other health conditions. So we had mental health parity legislation in 2008, it's part of the Obamacare. But basically what that means is by law, Medicaid and also a lot of private payers need to cover mental health and substance use conditions in parity with the way they would physical conditions. So what does that mean? It means that the same way if you are someone with cardiac disease, your insurance could pay for your Lipitor and it would pay for triple bypass surgery. The same way for addiction, we need to offer everything from what is the equivalent of the Lipitor to what is the equivalent of the surgery. And very often what's been available to people is either you can get the Lipitor, maybe, you can get the surgery, maybe, but it's not always available to where you are. So a big issue is kind of where it becomes a policy issue, is kind of almost a civil rights kind of thing, where for various reasons, mainly because addiction has historically not been covered by health insurance, it hasn't been treated that way. So that's a big movement in the field. Now, here's where I'm going to get a little nerdy and North Campusy on you when we're talking about addiction. So what is it? And I know a lot of you are neuroscientists, some of you may also be behavioralists. So take a look here. This is the DSM-5 criteria. And what it is it lists 11 symptoms. 2 or 3 of these you can as a mild substance use disorder, 4 or 5 as moderate, 6 or more severe. Now, I'm going to open it up if anyone wants to raise their hand on this. But what do you notice, particularly about what I have underlined here, looking at this diagnostically? What jumps out to you? That was perfect timing. My wife just bought me coffee during that pause. Bueller?
I would say the personal cost.
Personal costs, yeah. So very much in that, like what it does to your life. Absolutely. See something here in the chat here. Oh, no, that was just the notice from before. So personal cost, definitely. And I think you're getting at the point here because it's personal cost, but look at this objectively. So who is to say longer than you meant to? Who is to say you want to, but you can't? Who is to say what a lot of time is? Who is to say not managing what you should do? You see that a lot of this, if you take this out of a diagnostic manual, this looks kind of judgy, doesn't it? I mean, this is kind of judging, telling people this is what you should do. Who's to say what an important social, occupational, or recreational activity is? Why is it an issue if I'm doing something that causes problems to my relationships? Why is it a problem for me to do something even though I know it's a problem and has personal costs? So what you can see is there's a lot of almost normative expectations in this definition in terms of this is kind of our idea of what it means to have a substance use disorder is very much tied in with judgments of how we're supposed to be, how we're supposed to operate as people, as citizens. And this is something that's broader within medicine, but particularly in addiction, because of the fact that it's one of those rare things where it's considered what John Stuart Mill would have called an other regarding behavior, where I have a right to do what I want with my body, however I'm doing damage to others. But what's interesting here in these definitions of how we define a disease is that it's defined by these kind of social categories. So just bringing that up. And then this is also where some of my wonkiness as a historian comes in. So this was my book based on my dissertation, and a lot of what I talk about is that Really, the modern conception of addiction as a disease stems to the late 19th century. And the late 19th century is a time when we see a lot of evolution in terms of the birth of psychiatry and psychology. Also, it's the development of mass society. So prior to the late 19th century, I lived in my village of 100 people. I rarely got to know people outside of my village. What you see in the 19th century in Western Europe and the United States is the development of what we call mass society. The idea that because of industrialization, because of the development of modern finance, your success, your ability to be productive matters to me as part of the whole. So if you take a look at the fact that we have everyone kind of being in this together, this social notion developing in the 19th century, at the same time as the development of addiction. So we have a few things going on. One is alcoholism at the time, framed really as a moral problem. If you look at people talking about alcoholism, it's always about the guy who gets his paycheck, spends it all at the bar, goes home, beats his wife. However, there was acknowledgement that alcohol could be quote unquote a merry substance and that it was social. It's something that when you use alcohol, it's something that you would go out, you would carouse, you would talk with friends. And if you think about it in terms of the rise of nationalism in communities, one marker of citizenship in different communities is how do you get intoxicated? So in France, you drink wine. In Germany, you drink beer. In Russia, you drink your vodka. So it was very much tied with that. Now, opiates, on the other hand, and I bring this up because when we talk about addiction in the late 19th century, opiates were the issue. Marijuana, very, very rare. Stimulants in the way we now have them, not really an issue. Now, opiate addiction in literature, in medicine, and a lot of things was considered rather than something that would make you more engaged and kind of jolly, friendly guy, something that would make you very passive and introspective. And this is talking about what the opiate high was like itself. And really the opposite of what it takes to be engaged in one's community. So Charles Baudelaire wrote about this. So, you have him, you have other romantics like Thomas de Quincey in England, talking about how opiates really bring you inward. And Baudelaire coined this phrase that I love of opiate use being an appalling marriage of man to himself. So rather than doing what you're supposed to do as a member of a mass society, really this inward turn that's not compatible with citizenship. And we see this in a lot of the concerns that came up in the late 19th century. So morphine addiction was a very big issue. The hypodermic syringe popularized in the late 1860s. Morphine was a new medicine that doctors started using as effective treatment for everything. Addiction became rampant, generally among physicians, and at least in a lot of the concern in the medical literature and social literature, particularly with women. So what these people have in common is, again, think about society as a fabric. Doctors and women are people who you think of as having a specific duty. Doctors to care for everyone, and women obviously make babies, make healthy babies, take care of the family at home. This was a big concern in the 19th century. Then also, as a lot of you probably know, the drug war has always been rife with race in various ways. So the same way that we Europeans use alcohol, the Middle Easterner would use marijuana. Opium would be something they would use in China. And there was a big concern, particularly in the UK and the US, the late 19th century, about immigration from China. And this is also the time of the beginning of eugenics, a lot of racial pseudoscience that would really reach its height in the 1930s. But there was concern about what they called an Oriental contagion, this fear that Chinese immigrants would come over, offer opium to people, often again, white women, and kind of spread their culture and their ways, thus denigrating Western culture. This was the fear. And then also, a lot of what I talk about in my book was really in the French context, but it really reached its height around World War I, which incidentally is when drugs became illegal. That there was a lot of association with opiates and alcohol with treason, the idea that enemies were working to corrode the social and political fabric from within. So what are some ways this took form? Well, in France, you have a genre of literature from the French colony of Indochina, now Vietnam, telling stories about people who were good, patriotic colonial soldiers A Vietnamese local introduces them to opium, and then they suddenly betray the country and join the resistance. Or in World War I, there was a lot of discussion of where does our morphine come from? And it happened to be that most of the morphine manufactured at that time came from German factories. France and Germany, mortal enemies. Therefore, you have that concern, both with alcohol and with opioids. And then you also have, with the Red Scare in the US, a lot of discussion of psychoactive substances almost being tools of sabotage. So the way we think of the Russians using social media recently, arguing that the enemies of freedom were using drugs this way 100 years ago. Now, this is where I would say there's a continuity. And if I'm losing you here, just chime in and let me know. But this idea of citizenship, we can think of as a very quaint 19th century thing. But here we have 2007, the Betty Ford Center, one of the leading addiction centers in the country, gets together and has a consensus panel on what does recovery mean. And they come up with a three-pronged definition. And again, what I have underlined, look at how normative this is. Look at how much this doesn't seem like I'm getting better from a physical ailment, but I'm behaving the way I'm supposed to. So it's a voluntary lifestyle recovery, being better from addiction. That means abstinence from non-prescribed drugs. Also conveniently, as you'll know, if you've ever been to an AA meeting, smoking is fine. Tobacco doesn't count in that view, just a side note. Personal health is defined by the WHO, including independence and spirituality, highly normative expectations of how we're supposed to behave. And the third word they said outright, citizenship, living with regard and respect for those around you as defined and measured by definitions of social function and environment. And later on, when they got some flack for this, they specified not so much performing duties in line with expectations of the state, but participating in the rights and responsibilities of social life. So you see how this is very much shaped by expectations of behavior of how one should act, how it could be highly political. And also just, again, it's the only condition, one of the only conditions I can think of. You have it to a degree with mental health as well, where in this definition, you don't have freedom from infirmity. You don't have, I mean, you do in terms of the physical health, I suppose, but it's not about eliminating disease, it's about acting better in many ways. So I think it's important to keep in mind as a background, and this isn't to say addiction isn't real, recovery isn't real. That's what I would have said back in 2008 when this was all academic for me. But having done work in the field and talked to people in the field, I realized that's not the case. But it's important to keep in mind that these political assumptions really shape the way that we approach all of medicine, and particularly when we're talking about addiction, given that. So with that, maybe I'll pause. Do people have questions so far, just on kind of that background on the first part before I go into some of the details of what's happening in the field today? Okay, great. Well, pop in if you do. So some of the key issues in addiction today, just to give a quick overview for those of you, because I think a lot of you probably spend time in the lab, but maybe not aware of how that work you do in the lab translates into what's happening kind of in the broader world. So just an overview of that, and again, happy to discuss any and all of this. So one issue we have is that most addiction treatment programs, particularly here in California, have traditionally been social model programs. And what we mean by social model is rooted in AA philosophy in some way, shape, or form. The idea that addiction is a spiritual malady. So therefore, it has a spiritual solution, which would involve the 12 steps. It involves giving back. That goes very much against or it's difficult to square always with the idea of addiction as a brain disease. Because again, what organic disease is cured by giving back and being a good person? So there's that incongruence with the workforce we have and the programs that have been in place for 50 years versus the science we've been getting in the last 25. That's one big issue. Also, I have here workforce is the 13th step being an issue. And what that is that a lot of the traditional workforce are people who don't necessarily have the kind of training you would expect for people providing a clinical service, and that they don't have master's degrees in counseling. What they have is a lot of lived experience. And often people who entered this were people with criminal records who were in recovery, couldn't get a job. What are you going to do once your recovery is set? Oh, I'll become an addiction counselor. I'll pay it forward, which is a wonderful thing. However, as a result, we have a workforce of a lot of people whose knowledge is based in their personal experience, not necessarily science, clinical interventions, or evidence. And what that leads to is some skepticism and hostility towards medications in particular, because of the idea that a lot of folks have in the field. And it's starting to change, but it's what a lot of my work is about, is changing these attitudes. And that kind of the AA model is, I've been through this, so I can tell you what recovery looks like. So what that means is that if this is someone who recovered 35 years ago before, say, medications were available, they would say, oh, you don't need medications. I did it without medications. You should be able to do it without medication. So you have some skepticism in the field because of that. I see we have a comment here. It's often hard to engage clinical psychologists because the field is so overwhelmed by paraprofessionals. Exactly. So it's that you have a lot of paraprofessionals, and there's a degree to which they feel attacked by the science. And it's frankly, it's again, there's a white coat effect in that there are people who have these fancy degrees telling them what they should do, but we haven't been to the school of hard knocks. But it's again, the question I pose is, for me as an asthmatic, I can say, I don't want the person who treats my asthma's number one qualification to be that they're an asthmatic themselves. In a lot of medicine, you see support for this kind of thing, but there's a lot more to it.
Howard, this is Laura.
Yeah.
I posted a comment, and I think one of the things that we see, especially with epidemic of substance use, is that a lot of folks are saying, well, where is the workforce? Like, how can I get these treatments, these good evidence-based treatments out there? And then there's actually a lot of papers showing that addiction is not well represented in clinical psychology training and so forth, and in medicine as well. And I think, as you're saying, because the culture is so heavily entrenched towards people with their own kind of experiences, it becomes kind of this prickly kind of exchange where, it's hard oftentimes for, science-based models to find, a home, even though we believe that they are better than counseling. And we show that repeatedly through meta-analysis and studies, that sort of the undescript kind of like general counseling really doesn't do as well as the evidence-based therapies. And again, the question is, how do we get access to those therapies? And there's a lot of really interesting work, like the New York Times just published a big article on contingency management, you probably saw, right, and why people don't get it. And it goes back to a lot of the social political, aspects that you were reviewing with us.
Yeah, thank you for that. And that's exactly right. I mean, I think that it's a lot of this question of where's the workforce, and some of it is that, so think about this. You're in graduate school and you have a choice. I can go and start a private practice where I, see a bunch of depressed kids talking about their boyfriend or girlfriend breaking up with them. Or I can go into a field where I see people with these more serious problems, and my colleagues around don't have a clinical orientation. So they may be hostile to the way that I approach things. So it's difficult. There's a bit of a pipeline issue. And that addiction is kind of like, when you're making a choice of what to specialize in, it kind of winds up being lower. And a lot of it is that also, if you think about it just economically, if you have a workforce of people who are kind of, their life has fallen apart and they're getting it together, you have a lot of addiction counselors who are on food stamps throughout the state. Their pay is so low. So again, how are we going to build a workforce if we can't attract people because of the fact that it's just such a difficult field? It's working with arguably some of the most difficult clientele and the lowest paid. It's a real problem. So a lot of work that's been done recently has been creating credentials and what they've called a career ladder in addiction, to make it so that you can go from being the person who's kind of rough off the streets and enters as a counselor with lived experience and get the clinical training and some counselor degrees that advance you. And those degrees involve education in the evidence-based approaches. But a lot of what you find is still, you can have, and I work with a lot of providers who have these credentials, And they still say, if you're using anything from the neck up, you're not really in recovery. They still have these old school attitudes. Now, a lot of
Sorry,
our work, yeah.
just Laura, I was just going to interject that UCLA is a part of the problem in that they have, a program to extension, which is really AA based and not science based. So I think because there's kind of a business model to a lot of these things, I don't want to make it sound like UCLA is so, science based and so great, because if you take a look at what's offered through the, extension, it's really not good. It's not evidence based, nothing that we would want to be associated with, and they're making money off of it.
Uh-huh. Yeah, yeah. And it brings to mind there's almost a path dependency to it, meaning that it kind of locked in that addiction counseling as a field kind of became what it is in the 1970s. Then as a result, the people who have been in charge of it and become the self-appointed and recognized experts in addiction counseling are therefore people who were trained in those old models. And that so there's almost, I don't want to say a vested interest because that makes it sound nefarious. But there's a degree to which if those are established as the experts, then that's going to remain the expertise. And what is counseling? It's above all the social model, because that's what the founding fathers of the field, so to speak, were versed in. Now, again, this is changing. But a lot of work that we're doing at ISAP, and as you bring up, UCLA is a big place, so we have a lot of people maybe sometimes working in counter purposes. But a lot of our work is now we can go into a program and wag our finger at them and say, listen, here's the evidence. How can you not understand this meta-analysis? That doesn't really work that well. So a lot of our work is figuring out almost what they call implementation science and how to facilitate a culture change where the medical model is not the opposite of the social model, but rather making it that you can have the social model orientation, because the fact is it works for a lot of people. But at the same time, let's add the medical model to your tool chest. Let's add these evidence-based behavioral and pharmacological interventions. We're seeing in the field, this is starting to happen. Bigger providers tend to do it better. These are the ones that have more resources. They can afford master's level staff. Another problem that's coming up with this, though, is a lot of the programs that treat underserved communities, the programs that treat racial ethnic minorities, the programs that, when we think within the broader context of let's take advantage of these institutions that know their communities, a lot of providers who work in those communities are the most old school. They're going to be the most, they're often the most resistant to these things. And as a result, particularly as the market shifts with insurance and certification and things like that, those are the ones who are going out of business. So in order to evolve, there needs to be a certain program capacity. And the problem that the field is facing is that the programs that need to evolve the most sometimes die off rather than evolving. And the ideology has something to do with it, though there's also a matter of resources as well. Medication. So as I mentioned, this being a big one. So we have evidence medications for opioid use disorder and alcohol use disorder. There's a whole ball of wax within this. Particularly the fact that, well, there are other very damaging drugs we don't have medication for. I'll get to that in a second. But there's kind of a big development in the field. So for opioid use disorder, it was really changed by methadone, developed in the late 60s in New York, and really the system we have developed in the 1970s. Now, methadone is an opioid agonist, so it's something that you could potentially get high on. As a result of that, and also the time in which the methadone system was set up, it's very highly controlled. So to get your methadone, you have to go to a special methadone clinic to get your dose. When you're first in treatment, you have to get your dose on site. Someone watches you take your dose, unlike any other medication that I know of. Also, in order to qualify for methadone treatment, you need to have documentation that you've tried other things and it hasn't worked before. So very highly controlled and a lot of surveillance and burden. And that particularly, think about it, if you have a medication where for the first few months you have to go to your doctor every day, that's almost the same burden as, I don't know, I guess it's not like dialysis where it would take that amount of time. But a lot of folks, what it is they have to go at 5 in the morning, line up, get their dose before they go to work every day. High surveillance, high burden. Now, something that's developed since the 1990s, and a lot of this, the trials on this were actually here at UCLA, is buprenorphine. Now, buprenorphine is a partial agonist, and it's something that people can take that effectively will ward off withdrawal symptoms, but for someone who's not opioid naive, it won't necessarily get them high. And a beauty of buprenorphine is that there's less risk of the diversion because of the fact that it's more difficult to get intoxicated on it. Also, it's less controlled. So your primary care doctor can just take a couple of hour course for what they call an X waiver and prescribe you buprenorphine. So this is really, really promising in that now you can get medication without having to go through the whole rigmarole of methadone. I think some of the issue, though, is getting physicians to want to do it. So again, part of our work at ISAP is going into primary care and telling physicians, listen, you can just do this quick thing and you can treat a lot of people and save a lot of lives. The resistance we get with buprenorphine is physicians not even saying, oh, I don't want to get my license, but rather, I don't want to advertise that I give buprenorphine because I don't want my primary care office full of moms and kids suddenly with heroin addicts showing up in the waiting room. So a lot of our work is getting it implemented in a way that addresses the stigma and also kind of the social issues that are often attached to addiction. We also have naltrexone and Vivitrol, which are good for alcohol and opioid use disorder. Relatively low uptake in those. These are drugs that work by kind of blocking the high. Management is a challenge. Vivitrol has a lot of potential because what it is, it's a shot you get once a month. And then basically for that month, it doesn't really, it's difficult to get intoxicated. So, and like I mentioned now, the big issue is we have the medications, but how do we get them to patients? So a lot of focus on primary care. Also, particularly for the injectable Vivitrol is in correctional facilities right before someone is going to leave to help them avoid relapse, give them a shot of Vivitrol. That'll help them not relapse because the biggest risk window of relapse is actually when someone is released from incarceration. This also ties into another area we're working on, or that's big in the field, which is what they call screening and brief intervention referral to treatment. So integrating with mainstream medicine. So the same way that your doctor kind of checks your cholesterol, if it's a little high but manageable, he'll give you a medication. If you need to see a specialist, he'll refer you to cardio or whatever it is for cholesterol. I'm not a physician, I don't even know. But anyway, the idea that it's kind of a tiered system. So the principle is that your doctor asks you, how much do you drink? I know for me, it's been interesting. I've observed my doctor now asks me these questions and I observe it. And if I say, well, doc, I have a 6-pack a night, he's supposed to kind of have a motivational interviewing script, something to kind of tell me, educate me about the problem and enhance my motivation to cut back my drinking with the belief that that would work. And then if after a few months, I'm still drinking a 6-pack a night, he can refer me to addiction treatment. Wonderful on paper. What we're finding is that it doesn't really work for the folks we need it to work for the most. So the doctor telling you to knock it off works if you are having 2 glasses of wine a night and you want to cut back to 1 glass or no glasses, sure. However, for the guy who's having a handle of vodka or anyone who's using drugs, there's very little evidence that this works. One of the few successful trials on this was actually here at UCLA by Lillian Gilbert on drug use. But what was interesting about it wasn't a one-off in the doctor's office. It involved the doctor giving them the lesson and then having health coaches call for follow-up support. So the question of how to facilitate this is difficult. And also what we found, so the people for whom we need it the most, it's not necessarily working as well. Also what we find is that the referral to treatment part is hard. So let's say I have a real an alcoholic with serious problems. My doctor refers me, often I'm not going to go. So we're working on that. Another issue that we've come up is this question of parity. We want to cover SUD as much as we would other chronic medical conditions, as I mentioned before, but how do we do it? And particularly a big issue is there's an objective way for a doctor to know, okay, you need heart surgery. But how do we know if someone needs residential treatment? So in the field, there's been some developments of trying to come up with objective evidence-based ways of determining who needs residential treatment, but we're not really sure how well those work. That's been a challenge. And as I mentioned earlier, how do we bring social models up to the quality and capacity of other medical specialties? Another thing that I'll bring up, and Zoe, feel free to cut me off if we want to, I didn't realize how long we're going here, is there are two epidemics going on. And the one you always hear about is the opioid epidemic. That's the one that's been every headline everywhere. Largely, I would argue, because there's a body count with it due to overdose deaths. And the body count, it's a lot of whites in the suburbs. So I think that there's a socio-political frame to this, because the other thing, if you go into a typical program here in LA and say, so, hey, guess what? We have buprenorphine for this opioid problem. Most of them will say, enough with the opioids. What do I do about methamphetamine? That is the big burning issue in a lot of these programs, but it's difficult. It hasn't gotten the same attention because it hasn't had the overdose problem. B, socioeconomically, it's kind of different. It's also rarely iatrogenic. So opioids, I think the problem has been rooted in doctors' offices, therefore a lot of the solution has been. With methamphetamine, not so much. And also we have the medicine for opioids. For methamphetamines, we don't. So there's a big socioeconomic divide, but also if you think about just kind of where's the social mayhem coming from among underserved populations in particular, it's really much more methamphetamine than opioids, particularly here in California. This is something that people are starting to recognize. Lara mentioned the recent New York Times article, which actually I'll bring up in a second, but that tied to methamphetamine use. And then some other issues, just broadly, thinking in terms of science and policy. Criminalization and regulation, something we're seeing. Another few states legalized pot the other week. So the war on drugs sucked, but what would be better? Something that Mark Kleiman, who used to be a big drug policy expert at UCLA, talked about was, well, okay, so prohibition's terrible, but it's, what are you gonna do? Let everyone use everything? Have second graders using meth? We don't want that either. So we need to figure out ways to promote public health and safety while at the same time not being so heavily handed. How do we decriminalize but not commercialize? This being a big concern with marijuana. So certainly no one is saying we should lock people up, yet at the same time, we don't want marijuana to become like alcohol and tobacco. In particular, when I'm watching a baseball game with my son, I don't want the seventh inning stretch to be brought to me by Howard's Cannabis or something like that, the way it is with Budweiser today. One issue is that when we commercialize, what we're doing is we're making profit off of spreading something that causes a lot of problems. So what that means is the R word, and that's regulate. Now, as you know, in this political environment, regulation is always rife with a lot of issues and competing interests. So that's an issue. How do we treat it without coercion? A lot of folks that you'll talk to, particularly in the 12-step models, you ask them, so what was the turning point on the road to recovery? And they'll say, when I woke up in a prison cell, when my family got taken away. So you have a workforce that says you need to hit rock bottom, but we don't want people to hit rock bottom. And this is a condition where denial is a symptom, kind of. So it's an issue the field is thinking about. As we untie the addiction prison complex, how do we ensure that community-based services are available and accessible for those who would have been incarcerated in the past? So again, no one wants to lock people up. I think everyone agrees on that. But we want to avoid what happened with mental health in the 1960s. And what that is in the 1960s, mental health deinstitutionalization, they said, we're going to let people out of the mental hospitals, they'll live free in the community, and we'll provide them with the supports they need. Here we are 50 years later, and that still hasn't happened. So we need to be sure that we actually get people the care they need and that deinstitutionalization doesn't turn into neglect. And then another one for me with marijuana, and this is particularly local in LA, there's been a big focus on we want communities of color and communities that have been adversely affected by the drug war to benefit from marijuana businesses. What I worry about is that if you look at when is marijuana use most damaging, it's for youth and it's when you're marketed aggressively. So if we are saying that we have an underserved community where people are coming home from prison and now can get in the pot business, great. But are we doing good if that means that they're then going to build businesses that enrich themselves by encouraging marijuana use, particularly among youth? So I think it's a double-edged sword. in that certainly we want to rectify social injustices of the past, but we have to understand that even though the war on drugs was harmful, that doesn't mean that complete liberalization is a good thing. These things can still do a lot of damage. And from a public health perspective, this is something I worry about as the pendulum swings the other way. So what do you think? That's what I got. Sorry that if that was overly dense, that was denser than I planned, I think. But definitely open to any questions or comments people have on any of it, and happy to answer any questions or review anything that we may have glossed over.
Howard, I have a question.
Mm-hmm.
This is Jackie. I'm a postdoc in behavioral
Jackie.
neuroscience. I work on the kind of basic science mechanisms of how we understand addiction in rodents. So I really found your talk pretty interesting. What do you think is working in the clinics right now, and where do you think we should be putting our resources kind of going forward?
Working. I think it depends a lot on the substance, first of all. I mean, I think buprenorphine really does really can work very well. A lot of resources are going into that. I think the thing in terms of what can we do differently. So I thought I had it up here, but I guess I didn't. But the treatment of stimulant use disorders, one thing that's effective is contingency management, which is effectively the use of incentives to get people to change their behavior. Evidence shows that for methamphetamine stimulant use, it works really well. However, it doesn't work well once you stop providing the incentive. And the incentive can be anything from you get $5 per clean drug test to, if resources are scant, every time you come to a group, you get your name, you get to put a piece of paper in a fishbowl. Every once in a while, we draw a name out of the fishbowl and that person gets a TV or something like that. So I think that coming up with creative ways to treat would be effective. I think that primary care integration is the other thing, in that I think it's really, really appealing, the idea of being able to treat it like any other disease, take away the stigma, take care of it in my doctor's office. But we have the physician comfort as well as the physician burden is a big issue. There was a study that if primary care doctors did all the preventive care we asked them to, they would spend 9 hours a day just doing that. So with addiction, we're adding one more thing to the table. I think that's difficult. The other area clinically, and again, Medicaid is the biggest payer of addiction services. So a lot of it is tied in with services for low income folks, but case management is the key thing. Case management being help with establishing your benefits, getting your disability benefits if you need, getting housing, stuff like that. Those are things that are kind of clinical/social services that a lot of folks, particularly in the public system, really need. And it's difficult because without getting your life together, it's hard to recover well. But I think that we as a system, if we think about medical interventions narrowly, it's hard because we need to tailor the environment and set people up for success. So programs that are successful are able to do this, but that's also a big challenge for the group as well. Great question here. In your opinion, how do you think Oregon's new stance on decriminalizing possession and use of small amounts of drugs will influence addiction in the state? Fantastic question. I don't know. It's an experiment. Folks at RAND do a lot of work in this area. Bo Kilmer and Rosalie Picalu, who's now at
Bo is speaking to this group next quarter also. So if you guys
oh, there you go. All right. Well, remember to forget everything I told you because he's smarter than me when it comes to this stuff. But yeah, so I think it's going to be really interesting. I think that it could have an effect, but the big thing in terms of spreading use, and I don't know what the evidence is, Bo can speak to this. Decriminalizing, I think it's okay. That's not the issue in terms of public health as much as it is commercialization. So what would worry me would be is if suddenly you could have methamphetamine businesses and heroin businesses and advertising and things like that. I think decriminalization is good in that what it does is it basically just addresses a lot of the social iniquities. However, also I think that again, this is it's a self-perpetuating thing based on how things have been set up, but that so many people, when you talk to them, they say, I wouldn't have made the change unless a judge made me, or unless I was forced in. So you do wonder about what is the stick versus carrot balance going to look like. And I think it's a good thing. However, I think it makes it all the more challenging for us to get people into care, particularly because an interaction with the criminal justice system can often be a linkage to help. So I think it's a double-edged thing. How does this relate to the current homelessness crisis, and what should be the first step in targeting this? Addiction does relate to the homelessness crisis, without a doubt. Studies that I'm doing with homeless programs here in LA, we have about 50 to 60% of folks reporting what would look like substance use disorders or problems. I think, however, there are a few things to acknowledge. One is that life on the streets is hard, and that things we would consider substance abuse would for other people be considered survival. And that it's the only, like, who wouldn't be depressed or anxious after a lot of time being chronically homeless? And for those folks using marijuana to soothe, I understand it. Also, another thing that I've heard a lot, which I wasn't aware of till I started talking to folks, stimulant use, very high, particularly methamphetamine, but a lot of folks, you ask them why, it's because of the fact that, well, if I fall asleep at night, I'm gonna get raped or killed. I have to stay up all night. So that's why I'm using my methamphetamine. So I think it's very difficult in terms of unteasing we think of it often as someone uses substances, it doesn't get treated, at least to homelessness. Certainly that happens. What I worry about in this field is there's so much focus in the homelessness world on people with substance use disorders and mental health disorders, which is a big part of the population. However, it's also a social and economic issue that has to do more with rent control and people having jobs where they can afford the rent. And I do worry that we as a society are passing the buck onto behavioral health more than we should, because you have a lot of homeless families and a lot of homeless folks for whom there isn't a behavioral health history. So I think it's tied in, but I do hope that we can not let that take our eye off the ball when it comes to homelessness. So that's a great question. To what degree do the issues related to addiction treatment being US specific or global? Are there other countries doing a better job with addiction, and what are they doing better? Yeah, a lot of it is US specific. I think that the peculiarities around methadone, I believe, are US specific. It's an interesting question because they say, oh, why don't you do what they do in Switzerland or what they do in Holland? And certainly there are some things where it's better, and Bo will be able to speak to this much more than me. However, I think it's another thing that ties in, and again, I always come back to this, but what works in Switzerland might work in Switzerland because they're treating Swiss people. They're not treating American people. We have a culture where we use substances in a different way than a lot of Europeans. I think that that can be a big part of the issue. We also have the commercialization, which again leads to the problematic behavior. But I think that there's, in general, they also haven't had that social model background as much as we have, so that it's treated much more by medical professionals than it is in this country. And I think that that helps. It's interesting. I recently had a paper where we had one reviewer from Portugal who said, this is an interesting paper, but what on earth are you talking about? Why do you have these people without bachelor's degrees doing this work? I thought that was really enlightening right there. What lessons can be learned from tobacco or the depression fields on being integrated into primary care and reducing stigma? I think a lot. I think that depression, that's exactly the kind of thing where it's so widespread, where the screening with the PHQ-9 can be helpful. I think with tobacco, I think it's more instructive, actually, because you have a combination of all the doctors being on board telling you it's bad for you, but you have also had a culture change, and particularly prevention messaging being something that seems to be very salient in American culture. And you see this when you see the truth ads, which is, if you're using these substances, it means you're a sucker because big business corporations are screwing around with you. The fact that there's big tobacco as an enemy and you're being manipulated seems to have really made a dent in the tobacco world. And of course, with vaping and stuff like that, it's now dressed itself up in a new form. But I think that kind of from the public health messaging, tobacco's taught us a lot. But yeah, I think that integration into primary care is key. But I think with depression, it's a similar thing in that I go to my doctor, I'm depressed, he can give me, sure, he'll give me my Prozac. However, what if that's not working and I need something more? Then it becomes a lot trickier in terms of getting me to a psychiatrist, getting me to a good psychiatrist. And I don't know to what degree the referral to treatment pipeline works as well for the more severe cases in mental health as it does in addiction. That's a really good question. It's something worth looking into. Another question here about my position on what the evidence shows about supervised injection sites, needle exchange programs, et cetera. My position is non-existent. I don't really have one because I don't know it that well. Evidence I know about needle exchange is that it works very well in reducing disease, and that also it's good as a way to get people into treatment, in that you can have people come there, they're getting all these services, and you say, hey, we're here if we need you, but if you're not ready to change, keep doing what you're doing. That seems to be a really good thing. It's interesting though, because I actually, for another project, was putting together kind of a training curriculum for a county on this. And it said exactly that, needle exchange can actually be a bridge to treatment. Then we ran it by the needle exchange programs and they said, don't say that. That's not what we're about. So there's a disconnect between, I think, making the argument at the big level versus the people who work there who definitely don't see it that way. Supervised injection sites, maybe there's some in the US now or some were recently approved, I forget. I know evidence from Canada is good. I mean, what they're particularly good at is reducing the spread of disease. And I think, again, by just providing a supportive environment, they can't not be beneficial. A supportive environment to get people the help they need, whether it's directly getting into treatment or other pro-social things that will help them improve their lives. But as for the evidence, it's not an area of expertise for me. Oh, what is needle exchange? Good question. So needle exchange is that I can take my syringes that I've used, my quote unquote dirty syringes, to a place and for free exchange it for clean needles. And not just that, but I can get clean cotton, clean other equipment I need to inject drugs. The logic behind it being that if I have a free place to do it, I'm not going to share needles, therefore I'm not going to spread HIV. Therefore, I'm not going to spread hepatitis. And then certainly COVID, I would imagine as well. But it's originally as an HIV initiative, and evidence shows that it works pretty well in reducing HIV exchange, HIV among people who use heroin. Because I think that that's another issue to bring up, I think, in terms of this history, it keeps in mind is that LA County, for example, substance use is not part of behavioral health, it's part of public health, because of the fact that so much attention didn't really come to the addiction field until it became tied up with HIV in the 80s, being that it's a health concern because now it's spreading this deadly disease. With HIV, the whole thing was one of the major vectors was needle sharing among people who inject drugs. So as a result of that, even today, as you might see in your NIH grants, depending on your field, for a while there was a thing where it's almost like you would get bonus points if you could help address HIV in whatever you were doing, because of the fact that a big kind of background theme in a lot of addiction treatment has always been, we're not just treating addiction, but this is also a secondary way to get at HIV. So thank you for reading that up. That helps contextualize things a lot.
I have a question also just before we end.
Yeah.
So in the kind of, you're talking about this like social framing of addiction versus like a medical framing. And obviously the kind of ideal world would be somewhere in between, since like, 12-step programs and community-based programs and kind of CBT type things like that have shown to be effective also in certain situations. So it's like whatever kind of works for you or for the most people, like within that spectrum. So in terms of like messaging and policy and kind of communication, what do you think, I don't really know how to phrase my question. Like, how do you think you as a scientist or as a researcher, as like someone who works in this field, you can be most effective in translating the evidence and what works to the public, since it seems like a lot of the bad parts of addiction policy stem from that original kind of social understanding of like, you're a moral failure, and like the disparities in different policies for different drugs and all of that, like rooted in the, you know, 70s and the 80s and all of that. Like, how do you think we can, because then the other side of it is make everything legal and commercialization, which obviously, as you're saying, that's not going to be necessarily helpful either. So how do you think, like, in terms of messaging, you could be most effective and kind of?
I think that's a great question. I mean, I think that in terms of this question of social or moral, it's interesting. There's been some research that's shown the messaging on brain disease, like telling people that addiction's a brain disease, doesn't really mitigate stigma. In some cases, it actually increases it. Because, I mean, telling someone, wow, these people, their brains are damaged, that's kind of stigmatizing too. However, language is very important. There have been studies where they go to people and they say, okay, so Joe is an addict and did XYZ, what kind of treatment should he get? And then they go to other people and do the exact same story, but instead of the word addict, they say Joe is an individual with a substance use disorder. And people tend to be more sympathetic to the individual with a substance use disorder. So I think taking the clinical language, I mean, the word addiction is frowned upon, particularly the word addict is frowned upon. Then it gets to this question, what about gambling addiction? That's not a substance. I think that that's a whole other bowl of wax I know nothing about, and you should have Tin Fong on to talk about that. But in terms of the messaging, I think I think one effective thing is to destigmatize it with language. Another is to talk about how treatment can work and it's a good investment. A lot of it is that treatment might involve things that are counterintuitive. The one thing an addiction treatment never wants is to be on the front cover of the LA Times, because it's never going to be a good thing. So it's hard because in behavioral health, there's a lot of stuff where if you're a reluctant taxpayer, wait, you want me to use my tax dollars to pay for someone to go to an art class? You want me to use my tax dollars to pay for someone to go for, to get rewarded for a clean urine test? What kind of medical treatment is that? Yet, I think we need to get to a point where we accept that. And that's part of the broader point of just, we need a broader sense of community, because if we're going to think of addiction as an illness of isolation from and more congruence with the community, we need to build better community. So this ties into the broader issue of just social cohesion and things like that. And as for messaging, I think it's important for us to find a way to become an advocate for criminal justice reform and social policy that's beneficial to underserved communities without going too far the other way and saying, oh, well, it's just, you know, white people being racist when they say addiction's a problem. I have a lot of friends who, you know, they'll tend to say it's gone even to the extreme where it's like marijuana is suddenly the magic elixir that can cure absolutely everything. And it's only the pharmaceutical companies that have been evil and kept us from doing this. And we need to be honest. We need to say, yes, what we've been doing was bad, but we need to acknowledge what the other end, if the pendulum swings too far the other way, what it would look like. And people often say, oh, well, look at prohibition. That was a success. Actually, no. Or after prohibition, like what a success that was. No, because look at all of the damage alcoholism causes. Look at all the violence it causes. And public health wise, it's been a disaster. So we actually, if we could go back in time, we would regulate a lot more. And I think we need to not repeat the lessons of ending prohibition in the 1930s now as we go with marijuana and other things, because the last thing we need is the same way that I can't watch a ball game without Budweiser having an ad with girls in bikinis playing volleyball. I don't need that with my marijuana and my heroin and my meth as well in the future if we go down that route.
Great. I think we should end there because it's past, well, me it's 2, for you guys it's 11. But thank you so much. I mean, I love hearing like the historical and medical perspectives coming together. So personally, thank you so much. That was great. I think everyone got a lot out of it clearly from the amount of questions. And yeah, thank you guys all for coming. And we're gonna have some more. So we're the neuroscience communication group. So we're not like an addiction group, but we do have a good amount of talks on addiction policy coming up. So keep an eye out for that. And yeah, thank you again, Dr. Padwa. That was great.
Yes, thanks. Email me if you have any questions or just want to shoot the poop on any of this. All right, have a good one.
Okay, thanks guys.
Okay, bye.